Now, it's really a great pleasure to get to introduce Dr. Cuthbert today. I was looking over her resume, and it's quite humbling, to be quite honest. She's accomplished an amazing amount in her relatively short professional career thus far. She is currently serving as the chief of the Newborn Screening and Molecular Biology branch in the National Center for Environmental Health at the CDC. Prior to that, she served as the biochemical director the director of the biochemistry lab at the University of Miami. And then in advance of that, she did her training both at the Hospital for Sick Children in Toronto and did a stint at the Mayo Clinic in Rochester, Minnesota. So without further ado, I'll introduce Dr. Cuthbert.
Thank you. It's okay. Probably would give me some time to actually get adjusted here.
Sorry.
Thank you. I'm on now. Okay, it's a pleasure to be here. And literally, we are not quite across the street, but we are close enough, about 50 minutes away, on the Chambly campus. And much of what I will be presenting today is a compilation of activities of a number of people, a lot of different efforts. And I have the awesome opportunity to tell you about them and what they've been doing. Now, we're going to be talking about implementation of newborn screening for SCID. Specifically, I will be talking about the experiences of Wisconsin and Massachusetts. It's important for you to realize that those were the first two states to start projects, to start newborn screening for SCID. But right now, there are a couple of other states that are also screening, and they have exciting stories to tell. But I'm going to start right now by moving forward. Just giving you a bit of an overview about this particular condition. And for those of you who don't know what SCID is, it is severe combined immunodeficiency. It's characterized by the absence of both humoral and cellular immunity. And just in case you don't remember your undergrad immunology courses, if any of you have taken it, cellular immunity protects against viruses, fungi, and opportunistic infections, mediated by T cells and natural killer cells. And humoral immunity uses antibodies to protect against infection with bacteria and viruses. And that's mediated by B cells and T helper cells. Now, it's very important to realize that SCID, classical SCID, has a very profound defect in T lymphocyte differentiation and function. There are about 15 different genes that are known to cause SCID when they're mutated. And certainly because of newborn screening, we're finding that there might be more. The genes that we do know about include both X-linked genes and autosomal recessive genes that have that kind of that form of inheritance. And here's just a couple of the genes that are actually known. There's cytokine receptor genes, antigen receptor genes, and other. In terms of the clinical presentation, when the mother's antibodies wane during the first few months of life, the infants who are affected with SCID start developing infections with very common and opportunistic pathogens. And again, it's very important to stress that babies do appear normal at birth. So you can imagine if you do newborn screening and this has happened, you are presented with a very healthy looking baby, and mom and dad are going, there's nothing wrong with my child. Why are you calling me in, and why do we have to do all of these tests? But because of the disease process that's occurring, these children and these infants develop disease to vaccination, especially with live viruses, specifically rotavirus, because that vaccine is given within the first year of life. But again, they will also be susceptible to live viruses from measles and varicella. So they will develop recurrent infections. Generally, we say about 3 months, but that can actually happen a lot earlier. These infants will have chronic diarrhea, which will eventually lead to failure to thrive. Enlarged spleen and liver are very common, and usually death occurs about 1 or 2 years of age. It's also been called the bubble boy disease. I think you might remember John Travolta in his very, very early days. So the best hope, again, is to be able to identify these children pre-symptomatically and give them hematopoietic stem cell transplantation before they develop any of these symptoms. In terms of laboratory evaluations, CBCs are usually what is requested. Complete blood count, it will show severe lymphopenia. Flow cytometry, you will see, is something that is going to be requested by physicians for children who are thought to have this particular disease. And what you will see there is that all forms, again, of SCID will have very low T cells, evidenced by reduced CD4, CD8, CD3 measurements. Depending on the type, you may or may not have reductions in B cells and natural killer cells. And the physicians can order a mitogen stimulation, and that will actually show impaired proliferation of T cells. Again, low IgA and IgM. And additional evaluations will include looking at other markers in flow cytometry, looking at ADA and PNP levels, and certainly sequencing of candidate genes depending on the presentation and so on. What sort of treatment and therapy? Well, if a SCID diagnosis is suspected or established, these children are immediately referred to a clinical center and put into protective isolation, so no daycare. Certainly no live vaccines, and again, an emphasis, rotavirus is the one to be careful about because it's the main live virus given in the first year of life. Pneumocystis prophylaxis is given, leukodepleted blood products, intravenous and subcutaneous immunoglobulin. And again, for therapy, early diagnosis is absolutely the key to survival with bone marrow transplantation, enzyme therapy, and gene therapy, depending on what is actually deficient. So this is a slide I took from Lisa Kabrinsky. I thank her for many of the previous slides. Again, this just shows, do I have a pointer? Yes. And this just shows for any of the diseases that we're actually looking at and the kind of what happens when you've got newborn screening intervention. You've got the natural history of the disease X, or for SCID. You've got some time between birth and early clinical presentation of the disease. The child is going to be asymptomatic. You're going to have the early symptoms being shown, the late symptoms and so on, leading to disability and eventually death. So it's very important for us to intervene at this point with newborn screening that occurs at birth to identify the patients within that asymptomatic period so that we can actually intervene and alter the natural course of this child. I'm sorry. Okay. So the outcome overall is better health, reduced morbidity, and reduced mortality. So that takes us again to what has been done nationally. Now, in January of 2010, a month ago, at the Secretary's Advisory Committee meeting, SCID was the first disorder to actually be recommended by this particular panel to the Health and Human Services Secretary, for addition to the expanded newborn screening panel. And that was a milestone. That was a landmark event because very many other diseases, apart from the mass spec diseases that form part of the expanded newborn screening panel, that was the first disease that actually was recommended. And what was also very significant was that at a meeting that we had in Orlando, we were notified that the first SCID infant was pre-symptomatically identified, and that child came from Wisconsin. We've subsequently been able to identify a number of children subsequently who have SCID. That month was very key for us because later on in that month, Secretary Sebelius sent a letter and not only agreed to add SCID, to adopt SCID to the newborn screening panel, but she actually accepted and adopted the entire newborn screening panel because that wasn't done with the previous secretary. So essentially, the adoption of all 29 conditions at that point, and then SCID, the 30th condition, was adopted late in May 2010. And so what do we have upcoming? Part of her letter indicated that she would like to see a report generated. That's actually due sometime in May. So we're busy trying to compile this particular report. And she wants to know what the status of the states are with respect to implementation of this recommendation. And part of her letter actually stated this: adopting these, the committee's recommendations will provide the federal guidance necessary to assist states to voluntarily bring their newborn screening programs into alignment with the most up-to-date research, technology, and laboratory and public health standards and practices. So it's great to see that she has that level of insight. She does agree that newborn screening does impact public health, and she's very supportive of what is actually being done. So that letter is going to be written. We're getting together to actually put that report together. So I'm just going to switch gears and talk a little bit more about CDC's role. And this is my branch. It's the newborn screening and molecular biology branch. A few years ago, it was newborn screening branch and molecular biology branch. But a few years ago, both of these branches actually joined. And newborn screening found itself combined with a lot of individuals who had a really good understanding of molecular technology. And so I only joined about a year ago, and I'm very excited to be able to start embracing molecular technology and bring it into newborn screening. So it's fortuitous that it's all happening all at this point, where when all of the states are now being encouraged to adopt this particular molecular test. Much of the discussion, I'm sorry, I'm turning this off. So much of the discussion that I'm going to be talking about is actually centered around this particular group, NSTRI. It's the Newborn Screening Translation Research Initiative. It's a small group of researchers within the branch. It's led by Dr. Bob Boat, who's had a particularly strong interest in SCID and bringing SCID on to the panel as a disease that we screen for in newborn screening. So I'm just going to be talking a little bit about them and their activities. Now, the branch itself has been mandated by Congress, and this is part of why we get our money. But we are required to provide quality assurance materials to the newborn screening laboratories. And the actual text of it says that we need to provide quality assurance materials for newborn screening tests, provide performance evaluation services for the newborn screening laboratories, technical assistance, technology transfer, and assistance to ensure analytical validity and utility of the newborn screening tests. All for the purpose of, again, providing appropriate quality control and other performance test materials to make sure that we can evaluate the performance of new screening tools. So with that kind of mandate, and that again was through the Newborn Screening Saves Lives Act of 2008, of course, this is something that we absolutely had to be involved in. In addition to having that as a mandate, we also have funding that comes to our branch for SCID. And our branch has been involved in funding and the administration of the first public health pilot studies for newborn screening of SCID. The two laboratories and the two states that have been involved were Massachusetts and Wisconsin, and both of them have been getting approximately $500,000 each for the last 3 years, from fall 2008 onto fall 2010. So they're pretty much going to be wrapping up their projects with us by the end of this year. In addition, we were able to support a SCID newborn screening pilot study among Native Americans, and that study was amounted to about $100,000 a year for 2 years. And we do have, it is possible, again, you have to realize that we're under continuing resolution, so we're operating on a zero budget. But if we do get funded, it is possible that we will have money also, as we did for Massachusetts and Wisconsin, to be able to fund states in the implementation of SCID. So we're really hoping that the budget will be approved so that we can give some good news to very fortunate states that we get to work with. All right, so NSTRI, again, the Newborn Screening Translation Research Initiative, and again, that's led by Dr. Bob Boat, has been very a very vocal group and a proponent of SCID testing. And very early on, they started preparing reference materials for SCID, and they currently have those reference materials available for state laboratories who are interested in implementing SCID, and also for the states who are currently testing. They've also developed a novel method for the detection of SCID, and I'll be describing that in the next few slides. Again, that's using something called a TREC assay. It's looking at a certain fragment of DNA. What's novel about this particular method is that it's in situ. All of the other methods done by the states currently have a DNA extraction step, and then they use a small volume to actually do the PCR analysis. But we do everything in situ. And this particular group has also been very much involved in training, providing updates to the Secretary's Advisory Committee and so on, to several state laboratories. And last February, there was a workshop on SCID reference materials, on the TREC assay and so on. And we had May Baker, who's from Wisconsin, the Wisconsin laboratory, and Como, who's from the Massachusetts laboratory and state, presenting their method, presenting some of their experience to the rest of the states that were actually interested. I'm sure you see one or two people that you might recognize here. Those are our Georgia State personnel over here. Okay, and then later on in the year, because again, that happened in February. In May, we were informed, that the Secretary of Sebelius had adopted SCID, and there was a rumble. What do we do now? The states were looking around. How do we implement SCID? What sort of methodologies do we use? What's going to be required? It's an entirely new platform. It's DNA. At this point, some states had some DNA platforms in their laboratories looking at cystic fibrosis, and again, that was just part of some states' algorithms for how they were actually looking at that particular disease, but certainly it was not uniform. So now we're faced with something a little bit more uniform, and they were wondering, well, what do we do now? And in response to that, CDC, together with our colleagues in HRSA, funded a meeting, a national meeting, where we got together a target audience that included all the state newborn screening laboratorians, not all of them, but a representative of. We can't afford to bring everyone in. A representative from the follow-up program, physicians, newborn screening stakeholders, and all with the aim of, again, outlining the basic information regarding SCID and its detection through newborn screening, describing the basic testing methodologies of SCID, and specifically the implementation as well, so that they understood from the experience, what sort of issues that they might actually run into. And then we had a panel of wonderful physicians and who were talking about treatment and clinical management of these patients. So it was something where it wasn't just laboratorians. We had follow-up people, and we had people who were involved in long-term care of these patients actually coming together and discussing this very important issue, because none of us can operate in a vacuum, and that was very, very much apparent. So I'm just going to go through really quickly the TREC assay, and I don't know if we had molecular people here. It might be very trivial for you, the next couple of slides, but just to tell you, the SCID screening marker is called TREC, and TREC stands for the T cell receptor excision circle, and it really is just a byproduct. It's a DNA fragment, and it's a byproduct of the rearrangement of the T cell receptor genes during T cell maturation in the thymus. And so this piece is clipped out. It's an episomal piece of DNA, so it doesn't replicate with mitosis. So you can appreciate that newborns will have a certain level of TREC fragments in their T cells, and with every division, as they get older and older, that's going to be diluted out. So much so, if you do a TREC analysis of a newborn, you compare that with, Bob Vogt loves to say, you compare him, there's going to be a stark difference between the number of TREC samples. He's usually used as the negative control. So it is a good marker, but again, it's a little complicated because parents don't really like you bleeding their children. So that does provide some bit of a challenge for how we're going to get our material. With that being said, the peripheral blood level therefore reflects the T cell production in the thymus. So a SCID infant will not have a very high TREC value. A normal child will have a normal TREC value. So the TREC assay was originally developed to assess thymic function in HIV-infected infants, but has subsequently been adapted to detect SCID and other T-cell lymphopenias in newborns. It uses real-time PCR. And again, there are variations on the methodology. So the states will use something that's a little bit different. And it's going to depend a little on the selection of primers and probes, the DNA extraction procedure, whether or not you do it, and what kind of procedure you do, and also with the calibrators that you will actually use will impact the absolute value of the numbers that you actually get. So this is just a schematic of what that process would look like. You have your punch, your little blood spot punch in your test tube. It goes through 2 cycles of washing. And with that third wash, or not the third wash, a PCR master mix is then added, put into your instrument, and there you go. You have your values determined there. Okay, so in terms of the reference material, Dr. Vogt generated several types of reference materials. So there's a SCID-like reference material that will screen positive for SCID. And so you will expect that material to have a reduced TREC count, so that would be abnormal. But we need to have a normal control gene result. The normal reference material will screen negative for SCID, will have a normal TREC level and a normal control gene. And we also have an indeterminate reference material that will have an abnormal TREC result and an abnormal control gene. So he set about coming up with approaches to develop each of those. For the indeterminate reference material, he ordered leukocyte-depleted blood, adjusted the hematocrit, which is something that we normally do when we prepare our reference materials, spotted it onto paper, and in the absence of the leukocytes, it would be deficient in both TREC and in the control gene. For a SCID-like reference material, he ordered adult blood. Initially, he was using his own. Not allowed to do that anymore. So we order adult blood that has a low TREC content. They measure how much it's in there. And then they also take the added step of removing the mononuclear cell fraction. Again, adjust the hematocrit, spot onto filter paper, and you have your reference material that would be deficient for TREC only, but would have normal levels of your control gene. And finally, your normal reference materials, you have to acquire cord blood, and so this is where it becomes a little challenging because we have to make sure that we have good sources of cord blood, and make sure that when we get it sent to us over that period of time, we have a TREC level that is appropriate. And so he will either pool levels or really try to get cord blood that's recently been collected. Harvest the mononuclear cells and reconstitute with the pooled cord blood to levels that he would be using. So again, with the fresh cord blood, he will try to incorporate that at 3 different levels. So he has 3 different levels of normal values. Okay, so 3 normal levels are created that span the linear range of the assay. And of course, calibration material. Some of the states actually use plasmid, but we have developed a HeLa cell line that's transfected with a TREC sequence. What you want is 1 TREC sequence per transfected cell, and then you use the indeterminate reference material, you put that in, and so you can actually generate reference material with quantifiable TREC content. And so you can normalize across all of the states. That's something that we're actually working on, especially since the absolute numbers that some of the states are getting are a little different. Okay, so that's the reference material, and he has been giving out these reference materials blinded to states that are willing to participate in this, the states that are currently doing SCID testing. And there are currently monthly send-outs that he has right now. 5 blinded reference dried blood spots are sent out to the states. 5 blinded reference dried blood spots are sent out to the states. We currently have 7 enrolled participants. These participants, of course, are the 2 states that we started off with, and 2 of the other states that have joined to do a newborn screening. California joined, I think, in about August. New York started a few months later. We also have a laboratory in the University of California doing some testing, and PerkinElmer Genetics and PerkinElmer Life and Analytical Sciences have also developed methods, have developed and are in the process of generating an FDA-approved method as well. And we know that some other states are being approved as we speak. And I just wanted to say that specifically Wisconsin is screening for Louisiana. These are the states that are currently here on this slide. These are the states that currently have a testing within their own in-house testing. So Wisconsin, Massachusetts, California, New York are doing their in-house testing, but Wisconsin is receiving samples from Louisiana, and Puerto Rico is sending samples to Massachusetts also for their testing. So that is very exciting, and we're very glad that they're actually able to increase their capacity and be able to work with these states as well. Okay, so the focus of this part here is just to talk a little bit more about the Wisconsin and the Massachusetts experience. I'm going to talk a little bit more about Wisconsin and just describe very briefly Massachusetts' experience as well. Now, in terms of history and now their current status, way back in November, between November and December 2006, the Jeffrey Modell Foundation provided $250,000 together with the Children's Hospital of Wisconsin. They had matching funds to contribute to Wisconsin starting up a newborn screening SCID program. A month later, the Wisconsin newborn screening program was able to announce that, yes, in fact, they do have some money to actually start this program. And a few months later, they were working on optimizing the TREC assay and screening anonymized positive newborn screening blood cards. A year later, they finally launched newborn screening as a routine test in their state. And so at the beginning of this year, that marks 3 years that they've actually been screening. At the end of 2008, in October 2008, Wisconsin started receiving that grant from CDC to also help supplement the money that they received earlier. And they have, like I said, have been funded for 3 years for the implementation of SCID. And they're doing very well right now. Now this is an algorithm. I'm just showing one algorithm that actually shows how they might actually go about their testing process. So they will get their sample, and if the TREC level is above a certain cutoff, it will be called a normal report. For them right now it's 25. If their TREC value is less than 25, they will look to see whether or not their control gene is appropriate at an appropriate level. If it is low, it means that there's something wrong with the analysis or the sample. So they file an inconclusive report, request another sample, and it goes back again. If the beta-actin for them is normal, then they issue an abnormal report. If the child is premature, because they tend to have a lot higher number of abnormal reports, they follow the newborn screening guidelines and repeat the newborn screen every 2 weeks. If the child is full term, they notify the PCP, and the recommended approach is to do flow cytometry evaluation for T-cell lymphopenia. Alternatively, not preferably, alternatively they will request a repeat newborn screen for the TREC assay. Okay. So, in the 3 years that they've been screening, from January 2008 to December 2010, they've screened just over 200,000 infants. About 10% of those infants were premature. 90% of them were full term. They had about 159 abnormal results, 66 of which were full term, and 288 inconclusive results. And you can see that a significant contribution is made by the premature infants. In terms of the assay performance, their sensitivity is 100%, meaning that they have no record of any false negatives reported. No child has been identified with SCID that has gone through this particular process who's been missed by this particular test. Their positive predictive value has been shown to be 40%, specificity greater than 99%, and the detection rate for T-cell lymphopenias, and again, May was commenting, any child who needed a bone marrow transplant was significant enough to be included in this. They found 5 cases in the 200,000 babies that they've screened. So that puts it at about 1 in 40,000 infants as a detection rate for severe T-cell lymphopenia. So these are the 5 cases, the severe lymphopenia cases. We've got idiopathic lymphopenia. That child is on regular IVIG, and a bone marrow transplant is being considered. There's a patient with a RAC2 mutation with a successful bone marrow transplant, an idiopathic lymphopenia, bone marrow transplant, and a T minus, a T negative, B negative, NK positive SCID. This child has had a successful bone marrow transplant with normal TRECs, normalization of the TREC values, which is really good. And finally, they've had an ADA SCID, and gene therapy is being considered for that child. So I'm just going to walk you through one of these infants, infant A. Birth history, as you might remember, The child was normal. It was a male born at 40 weeks. There's no history of consanguinity. Day of life 1, the newborn screen was taken. Day of life 2, of course, the child was discharged home. Day of life 8, the PCP was contacted by the laboratory indicating an abnormal result for SCID. That child was called in, and as per their procedure, flow cytometry was requested, and that showed that there was an absence of T cells, and these T cell markers, you can see by the numbers, these are abnormal. NK was not abnormal. Well, actually, NK was not abnormal. And the repeated newborn screen showed an absence of any track. That child was subsequently admitted and put into protective isolation, put onto antimicrobial prophylaxis, and given intravenous gamma globulin. Breastfeeding was suspended, and they continued the diagnostic evaluation for SCID while this child remained in this environment. And in terms of the diagnostic evaluation, there were a number of things that were done. Genetic sequencing, research-based genetic sequencing with Jennifer Puck at UCSF, radiosensitivity testing, T-cell functional studies in fish for maternal engraftment, ADA testing that was sent to Duke. There were a number of genes that were evaluated for mutations, and there weren't any deleterious mutations found in any of them. And this just showed the results of a persistent T minus, B minus, NK positive SCID phenotype that was consistently found with this child. So the summary for this child is that this child was subsequently transplanted at day of life 77. She tolerated the procedure very well. She was eventually discharged and remained clinically stable. The molecular diagnosis is still not known, and again may reflect a novel mutation or previously unknown presentation of a SCID-associated gene. So it'll keep the molecular geneticists in a lot of business here. And again, this really emphasizes that implementation of TREC analysis in newborn screening can identify these SCID infants pre-symptomatically, and really allows the physicians a chance to be able to successfully transplant these patients while minimizing morbidity and mortality. The funding support is by the Jeffrey Modell Foundation, very, very strong advocates for SCID testing. Jeffrey Modell was the infant who had SCID and passed away, and their parents had generated a foundation in his name. The Children's Hospital of Wisconsin, Wisconsin State Lab, and of course we helped fund some of their activity. And moving on to Massachusetts. Massachusetts started off in March 2007. They generated their newborn screening work group, and I had a chance to actually visit with them about a year ago in February. And it's really a phenomenal group of laboratorians, infectious disease folks, immunologists, and so on, sitting around a table discussing all of the cases that they actually have. But again, it's bringing together a group of healthcare providers that hadn't normally sat around a table. So it was quite exciting to actually see them work together. In June later that year, they developed the TREC assay, worked at IRBs, and developed a statewide pilot. Later on in 2008, they also received the CDC award for 3 years. And they have continued statewide screening in Massachusetts. In September last year, they were able to start screening samples in parallel with Texas. It's not an established program yet. Texas is still looking at developing their methodologies and so on, but they've gotten very much involved in working with Texas. And so for the length of time that they have been screening, from February 2009 through on to December 2010, they had 143,000 initial specimens. Many of them were declined for certain reasons. So they wound up with about 139,000 valid specimens that they could actually put through the SCID testing program. 160 were just non-satisfactory for this test. 139,000 screened negative, 345 screened positive, and according to their algorithm, 29 of those cases went to flow cytometry. Of the 29 cases that went to flow cytometry, 18 of them had an abnormal flow result, so would be followed up more intently. One was within normal limits, 2 of the patients had expired. So of those 18, Massachusetts was able to identify 1 SCID positive, 4 patients with DeGeorge syndrome, and 1 infant with multiple congenital anomalies. 12 of the other cases are actually currently being worked up and have T-cell lymphopenia at some stage and are being followed for different reasons. Again, in Massachusetts, the sensitivity is 100%, no known missed cases. And their funding support has been entirely from CDC. Okay, and so that wraps up much of the experience that I'm going to be talking about. They have published on their experiences. Massachusetts has published, and so has Wisconsin. And I certainly want to acknowledge Bob Vogt and his group. For those of you who know him, Francis Lee and Golriz Yazdanpana have been doing an excellent job putting together the new method and generating the materials for the states. Lisa Kabrinsky is your own, who's been a guest researcher working together with Bob and providing considerable clinical insight. The Jeffrey Modell Foundation, Jalilio Jodu is our Washington partner at the Association of Public Health Laboratories. The group at Wisconsin, May Baker, the late Ron Lessick, Chuck Brokop, and Christine Sarugi, some of whose slides I stole in describing that particular case, and a number of different physicians and healthcare providers at different locations in Wisconsin. In Massachusetts, there's Ann Como, Roger Eaton, and Indranil Sahai, together with the SCID newborn screening work group, who's done a lot of work establishing their algorithms and determining how the entire process was going to work. So thank you, and I would be very happy to take any questions. Yes.
Please.
Carla, that was great. Great summary. Can you mention, as you were well aware, as you mentioned for the federal government, states are under incredible financial pressure currently, even to keep current newborn screening efforts going. Any comment on how much it will take a state, cost-wise, to get up and running, and what the cost per assay will be? Do you have any estimates of that yet from Wisconsin or from Massachusetts?
That's a really good question, and it's going to vary a little bit from state to state, and what they're going to be doing. The number that's been floating around and has been floating around for the last year about the cost per test is about $5. I know, that's very high. Don't flinch too much. You have to remember with molecular testing, again, this is bringing on in the implementation of an entirely new platform. So yes, they do have to consider very carefully what they're going to be doing, and it will require a significant investment. So anywhere from maybe $500,000 to $1 million, it depends on the states, and it depends on what they're going to be doing. Some of the states are going to be waiting for PerkinElmer to come out with an FDA-approved test. Some of them who are willing to get persons who might be able to develop the test in-house and pattern it after either Wisconsin or Massachusetts will follow suit. So many different states are in different stages in that process. Again, if the states have to get approval at different levels to be able to do that, and that's going to vary from state to state. They can increase the cost of the actual newborn screening test to help accommodate that, and that's something that requires approval from whoever is making that particular decision. So for some states, yes, they have gotten approval. Other states, not so much, because again, we're in a climate in which everyone is watching their pennies. So it is an issue for everyone. Some are managing to speak and to have good advocates on their behalf for newborn screening as a whole and for this in particular. So.
We have a question.
This is just, somebody has a question?
Yes.
Oh.
This is coming from Hans Anderson in Tulane. Were
Okay.
any of the DeGeorge positives diagnosed by malformations before newborn screening was reported?
I don't know the answer to that. But again, if they can email me that question offline, we can always check with the states, and we can get that information back to you. I just, while you can stick your hand up if you actually want another question, but I just wanted to indicate that, again, this was just the combined experience between CDC, Wisconsin, and Massachusetts. There's been a considerable effort by the National Institute of Health. They've gotten in excess of $1.2 million in this last year to fund a number of other states. So California is partially funded by that particular effort together with New York, Louisiana, and I think Puerto Rico as well. So they've got funding for that. The NIH has been developing some wonderful infrastructure as well to help the states, and they've been having some great conversation going among the states as well, as they're able to capture various elements to help states as they're implementing in the future. Yes?
We have one more question from Dr. Anderson in Tulane. Why did congenital malformations patient have immunodeficiency?
I don't know the answer to that. That's something that we'd be happy to talk to you about offline. Again, for that congenital abnormality case, there could be any number of things that would be wrong. And T-cell lymphopenia, remember, it picks up T-cell lymphopenia, so that could be one of many different things that would have been wrong with that particular child. So it might have been a consequence of whatever genetic disorder
Okay,
was
thank you.
associated.
Thank you, thank you so much, Carla. I wanted to bring to the attention of our HRSA activity of the regional plans include Lisa Kubinski, who is a physician here at Children's Hospital. We are hoping to invite her to be the regional champion for us in leading the efforts for SCID at the regional level. And she has accepted the invitation and will be posting some of the work she has started on our SERN website. So please, we'll have an award next time for the people who have been the most on the SERN website. The other thing, what's being discussed nationally is the regional treatment centers. And I know in our region, we have got 3 treatment centers currently, which are well utilized. One is at Duke, one is in Miami, and the third is at Emory here at Choa. So we are just having those discussions, and hopefully Lisa can bring the group together. We are planning on putting some funding in a grant for the next year to initiate some of those activities. So if anyone from our group, I know our state people are here, and if there are any comments, and I'll of course be in touch with Art to make sure that we keep him posted, and Trish and Angela and Paul in our offices to keep them posted about the regional activities. But anyone else in the group who's interested, and I was also thinking about Madhuri today, to really, because a lot of discussions are going on at the molecular issues to involve her a little bit of those activities. So any other input, any ideas we would welcome? And yes.
Just on a quick question, do you know, on the same note of having these regional treatment centers, is there any regional talk about having screening actually performed at regional labs as well?
Yes,
Just
and
to
that's
save
part
cost.
of the thing. I have actually talked to Lisa, and Lisa was going to meet with Art and talk, and one of the issues was, would we be better off doing regionally here in terms of screening also? But treatment, I know nationally, at the Secretaries Committee, the discussions have occurred at that level. So, but as far as screening goes, they've left it up to our region. So one of the goals is to put a work group together from our region, bring the people here, have face-to-face meeting, and have the key players in that. And Lisa has agreed to lead that effort. So I kind of wanted to inform everyone, and I'm planning on inviting Lisa to come to our division to meet with you, Angela, and Adria, to look at our current existing newborn screening program, because one of the things we want to do is centralize our efforts in terms of the short-term follow-up if we can, and coding. So I've had just very preliminary communication. No decisions have been made at this point. These are just discussions, and we wanted to bring our group up to speed, and all the people who are listening on this to what our efforts are. Anything else, Brian?
Just really quickly, thank you for coming. If you'll take a few minutes.